uh, for attending us in our Iraqi Recon webinar. Thank you, Dr. Ehsan Faraj, for attending. Today we will discuss about the periprosthetic joint infection, and we will discuss whether we can do it one stage or two stage surgery to get rid of that infection and seeing the best result for our patient. We will start by Dr. Ehsan Faraj, who will present his case now. Please, Dr. Ehsan, can you share your screen, please, now?
Thank you, Dr. Ahmed. Thank you very much. Welcome all my colleagues and my friends in our webinar. Hope that the benefit will be for to their friend Dr. Omar. We started by case presentation as an opening of our webinar about the infection in TK. 50 years presented to us with stiffness on 2019. When walking and patient history. This is our expert, Dr. Mahmood. Please, can you start?
Yes, thank you for my all friends. Thank you for those doctors who are seeing this webinar. One of the important subjects to discuss now, especially now, because we are so many doctors. I think a good number of doctors in Iran doing primary knee arthroplasty, and they have get a great experience in this. And it is, whenever you are working hardly, you working a good number, you face complication. The most important, the complication is the PGI in total knee replacement. I am going to discuss some 20 minutes what is the preferable procedure for me, two-stage reimplantation. But the important thing, I will correlate with the protocols, with principles, and what is going to improved in international consensus meeting, which achieved in Philadelphia before 1 year. So there is basis and principles. What can you do this? To start with the cases, this is the cases which we face it. All of the surgeons working total knee replacement.
Can you share your screen, sir?
I share already with the slides.
Yes, choose the screen and share it.
Play, you mean?
No. Choose the screen on the window of share screen, then press share to share it.
It's not share.
Hello,
Hello. Where is Ahmed, please?
Yes, I'm here.
Zoom, where I go to? Which?
Go to Zoom. You should first open the lecture, then go to Zoom.
I open it.
Go to Zoom, press share screen, find share screen.
Benim konuşmayı açsak bakacağın yerleri var.
I think there is something.
Okay, I can share it for you from here if you want.
Yes, yes, you can do it.
Aç bilgisayarı aç benim. Şey yapayım.
Okay.
Yes. Okay. Okay. So this is what we face it in our experience, that all of the surgeon may see these complication during their work. Next. So please, whenever you face like this complication, don't escape from this event. Always open the window, next, and face this problem. And if you cannot, please send it to another experience or another center. What will start with the plan, always plan when you are seeing this complication regarding the patient immunity and what is the type of the germ, what's the antibiotic going to be used, and it needs soft tissue coverage or not, and think about how you remove the implant, where it's stamped or not stamped, and what is the expectation of the bone defect you will face, and how doing the reconstruction, 1 stage or 2 stage. Next. What is the aim? The aim is first to cure the infection, second to restore the function of the knee, which you are going to do the surgery. Next, please. When they started the 2-stage reimplantation, Ehsan on 1983, he did the surgery for selected 11 cases. From this 11 cases, he applied 2-stage reimplantation. First stage to remove the implant, and after 6 to 8 weeks, apply the reimplantation. What he get, 5 cases was excellent, 4 is fair, 4 is good, and 2 fair. So started from the 1983. And after that, the other research, if you can see in different years they carry this research, the failure rate is about 10 to 12, and the success is between 88 to 92. Next, please. One research in Denmark, it showed that the failure rate was 30%, which is a huge number. But this is the only research that give this number. Next, please. What is you are going to do in knee when you get PGI? Please be please face this complication to doing everything, clean every biofilms and every dirty tissue, dirty bone, and apply all the instruments that you have to get extension gap and fleshing gap free of the infection. Next, please. The question, which is highlighted in international consensus meeting, what's about when you are doing the clearing or wound excision, first primary for the knee, do all metal implants to be removed? Yes, it's better to remove all the implants unless there is some implant which is change your future plan of using something is more reconstruction which cause morbidity. So it's better to leave this hardware. Next, please. Shall we use the solution? Yes, you can use 2 times. Every time is more than 3 liters. And under tourniquet with pulse valve lavage, and try to use the soft sponge to the canal, tibia and femoral canal by diluted iodine. Next, please. Then after you remove everything and you wash the wound, what's applied, then we come to the spacer block. This spacer block, you have many types of spacer blocks, static and mobile. Next, please. What's the benefit of these spacer blocks is to give better comfort and antibiotics sometimes mixed with it and easy reimplantation. Then limb length, you can keep it as the normal one and also gives better bone quality. Next, please. Shall all the spacers are the same? No. This is according to the surgeon experience and what is available. There is different type of the spacer, and the important thing is that keep the extension and flexion gap. It's safe to you and with equal lengths. Next. What is the disasters of the spacer? Everything, whenever you especially apply static spacer, there will be sometimes dislocation, dislodgement, and breakage of the spacer. So this is usually to be put in mind. This complication may happen. Next, please. Shall although one of the questions which highlighted and agreed about 90%, is it necessary to revise or remove or reduce the dislocated spacer? No, it's not mandatory unless it's causing skin necrosis or some of the complication regarding compartment syndrome. That's why this spacer need to be changed. Next, please. Okay, we come. What is the indication? We said it is two types. There is static or mobile or Hoffman type. What is the indication for use of non-articulating spacer? It's better to be used when after cleaning the knee, you face a major bone loss or there is lag of the ligaments, whether MCL or LCL in the knee, or sometime with the hip, as there is abductor mechanism. So in this case, it is indicated to use non-articulating spacer. Next, please. Should antibiotic placed in the cement? Also, this is agreed about 95 in the ICM. Yes, if you know the germ, you can put the antibiotic according to the germ. If you're not knowing the germ, apply one of the antibiotics which can against multiple pathogen. Next, please. Which antibiotic also, there is another question, which antibiotic to be added to a cement spacer in patient with periprosthetic infection regarding the MRSA, Staph aureus or Staph epidermis. They see that agreed about 99% to be vancomycin is the best antibiotic. And sometimes if there is multiple resistance, there will be a share between the bacteriologist and the surgeon what antibiotic to put. What regarding the mobile spacer, there is three types, where it's Prostelac or articulating spacer or cement when you model it according to the femur and tibia and apply it. For me, is more I am using articulating spacer. This is examples, okay, to how you apply the fixed spacer. You can apply it 1K wire or 2K wire length. This is for the fixed spacer, how you to apply it. Next, please. And also you can apply external fixation with it. And the other is the mobile spacer. What is the disadvantage of the fixed spacer? The disadvantage, it is always think about tibiofibral instability, patellar instability. Second stage is mandatory, may develop flexion, contraction, and stiffness of the knee. And there will be debatable about the function of the knee, because always in extension, he cannot flex it, or sometimes there will be easier breakage with high antibiotic dose. Next, please. And what's about the mobile Hoffman? I said this is the care is actually I am using in all my cases mobile spacer because I care about the alignment. I put a thin poly with a small amount of the bone cement with the antibiotic which is to the special organism. Next, please. And this is, if you, the number one is the cement, number two is the poly, And number 3 is the femur. And the number 4 is the cement of the femur, how you apply this articulating spacer. Next, please. And this is how you get the alignment, the patellar maltracking, and everything. Even there is, if it is stiffness, as Dr. Hassan present the case, there is some type of stiffness, you can get to tubercular osteotomy. Next, please. And what is the advantage? Better stability, kinematics, patellar maltracking. It is in trochlear groove, and there is less risk for the flexion contracture, and no risk for the breakage of the bone cement. And you can apply high dose of antibiotic. And foreign body, it will be not an issue like when we apply it in statics spacer, which is the bone cement is the always think about foreign body and micro reaction. Next. And if you comparison between static and mobile, all the regarding the bacterial skin layer collateral is in the benefit of the two-stage reimplantation mobile spacer. Next, please. What is the optimal timing for the reimplantation of two-stage? It's agreed about 95%. There is no time which say this optimal to apply for the reimplantation regarding of the hip and the knee. So just is to care about the clinical feature and some infection marker to be reduced. Next, please. And it's better when you going to deployment for the knee, it's to take a biopsy and together with agar 5 days. It's better to take 5 biopsy from the tibia, femur, soft tissue, capsule, and the gutters, and apply it 2 type, one of them slow and the other 5 days, and the brain heart tissue for 15 days. Next, please. And the final phase, if your spacer is applied, think about the how you to close it. There is soft, it needs for soft tissue coverage, and it's better to close with 1 minute film, and it's better to apply the drain at least for 2 days. Next, please. For these surgeries, and this is very important question, was highlighted also in the ICM. What is the optimum to be a number of PGI cases that surgeon must has experience to get an optimum outcome? And there is agreement about 97% that the number is 25 years at least annually you carry these surgeries that you can get the optimal outcome. Next, please. For me, as a personal experience, I did more than 50 cases according to the ICM criteria for diagnosis. And all of them, I am not a surgeon for 1 stage, I am a surgeon for 2-stage implantation. And I have 2 cases, it needs 3rd revision for it and cured. And 2 cases, next please, 1 case died because she had a renal problem and diabetic. The other we did arthrodesis. Next, please. And this is the case. The first case, this diabetes, she died. And the second case, I did arthrodesis for him. Next, please. So this is case I am presenting. Case the patient with the mesial injury with multiple fractures is about 50 years old, and has fracture in the femur, fracture in the tibia, and multiple operation done, external fixation, circular fixation. Next, please. And this is during his treatment for then 1 year, applied all type of external fixation and has multiple sinuses. Next, please. And this is the knee preoperatively with multiple shells. And the surgeon decided to do primary knee for him in the presence of these shells and these sinuses. And after they did, this is the primary knee, and get sinus, you can see with the poly is outside and loss of the skin coverage. Next, please. And my plan first to remove all the implants from the starting from the poly, then the femur, then the tibia. Next, please. And this is the knee after you clean everything. Next, please. I apply first stage mobile spacer, and this is the skin, and actually stiff knee, so that's why I did the tubercular osteotomy. And after 3 months, please, next, please. So we did also tubercular osteotomy and applied LCCK for him. Next, please. Next. And this is the fracture site previously, and this is LCK. And this is presented after 1 year with a clean wound. And the same patient had, next please, unfortunately, foot drop. I did before 2 months, arthrodesis, because the sciatic nerve injury, severe arthrodesis of the ankle. What is the home message is actually is that PGI is a challenging subject. Please plan for treatment starting from the skin and to the application of the last implant. Try to search about the germ and the host and the antibiotic, all of them, and it's better to work as a team. For me, two-stage reimplantation has low risk for failure, and it is working as a protocol, at least where there will be no nightmare for another infection if I compare to one stage of reimplantation. But put in mind, it is demanding surgery and has financial problem. Thank you very much.
Thank you, Dr. Mahmood, for your nice case. I'm asking all the audience to start writing their questions on the chat, so that I can collect them and redirect them to the faculty. Okay, Professor Omar, you can start your talk, please. Thank you.
Oh, okay, thank you very much. I am very honored to be here, and I'm going to share with you our one-stage exchange revision about the infected knee cases.
Yes, thank you.
And now I'm sharing with you. That's okay?
Yes, okay.
Good, good. Now, first of all, periprosthetic joint infection remains a serious problem. Despite modern operative technologies, knee implants, and rigorous perioperative antibiotic prophylaxis, prevention is essential, but the treatment of the infection aims for complete eradication with maintenance of the joint function. Incidence of infection is 1.63% within 2 years, 0.6% between 2 and 10 years. And as we know, there are some principles, and also now I would like to thank Dr. Mahmood. It's a very high quality and very excellent presentation. Thank you very much, Dr. Mahmood. And as we know, there are some principles. First of all, identify microorganism by using sonication and cultures. Complete surgical debridement that includes extensive synovectomy, removal of the mobile parts, low pressure post lavage, and successful wound healing. Appropriate antibiotic therapy if the systemic is better, and select and perform appropriate reconstruction. And when we look at the antibiotic usage, the antibiotic is effective against planktonic bacteria and effective against fragmented biofilm bacteria, but ineffective on biofilm, ineffective also against the Michelina's small colonies. That means the intracellular placement, localization of the bacteria, such as osteoblast, endothelial cell, and macrophage. We can see some bacteria is placed and located in the cells. And there are some surgical principles. And first of all, wide exposure, planned skin incision, radical excision of scar, removal of implant, preserve extensor mechanism. Our aim of during the surgeries, restoration of the mechanical alignment, restoration of the rotational alignment, restoration of the joint line, and achieving stable implant fixation. Restoration of the ligamentous stability with constrained implant. Dr. Mahmood shared us his case. Posterior stabilized component or TC3 and rotating hinge. Augmentation of bone loss, restoration of quadriceps functions. When we look at the algorithm for evaluating an infected total knee, the three critical steps. There are three critical steps. One, history, physical examination, and knee x-rays. Sedimentation rate, and serum CRP level. And joint aspiration is the very critical steps. When we look at the diagnostic tool, as we know, there are some biomarkers. For example, when we look at this table, first of all, if the infection happened before the 6 weeks, we can say that acute phase. And after the 6 weeks, we can say that is a chronic infection. The sedimentation rate, if it's higher than the 30 millimeters per hour, we can say that the chronic. And serum CRP level, if is more than 10 milligram liter, we can say that acute phase. And more than 10 milligram liters, we can say the chronic. Synovial white blood cell, if it's more than 10,000 cells per milliliter, we can say acute. And if it's more than 3,000 cells, we can say chronic. Synovial polymolecular leukocytes and more than 90% acute. Between the 80% of this, we can say the chronic. And when we look at this diagnostic and other tools, the new scoring based definition for prosthetic joint infection from the consensus meeting. When we look at the, first of all, main criteria, if two things, one of them, two positive cultures of the same organism, and sinistract with the evidence of the communication, the joint or visualization of the prosthesis, we can say that absolutely infected. And the second part, there are some minor criteria, and there are two levels. One of them, the preoperative diagnosis in serum and the synovial fluid. Now, elevated CRP or D-dimer, they give the two scores. Elevated sedimentation rate, 1. And in the synovial tissue or fluid, elevated synovial white blood count, they gave us 3. Positive alpha defensin, 3 points. Elevated synovial polymorphonuclease percentage is 2 points. And elevated synovial CRP is 1. That's okay. There's no problem. Do you hear me?
Yes, yes.
Hello?
Yes,
okay,
we can hear you.
Okay. And then the second part is intraoperative diagnosis. But before explanation of the intraoperative diagnosis, we can say that if it's all the scores and more than 6, we can say that infected. 2 and between 2 and 5 possible infected, 0 from 0 to 1 point non-infected. But there are some inconclusive pre-operative score, okay? And intraoperative diagnosis. When we look at the positive histology, 3 points, positive prevalence, 3 points, single positive culture is 3 points. This is the same as same in here. If it's more than the same or more than 6, we can say that the as a decision infected. Between from 4 to 5 inconclusive, less than 3 not infected. We can say it is very important things. When we look at these tables, preoperative period, we can say that just sedimentation rate or CRP level is, when we look at all the scores, completely 3. That means the possibility of infection. But we have to add some synovial score, as you see here, if there is an infection. And joint aspiration is another thing. Before the aspiration, stop the antibiotics for from 2 to 6 weeks. Repeat aspiration if culture grows potential contaminants such as coagulase negative stuff, corynebacteria, Streptococcus, Bacteroides, Propionibacterium, Echinus, and Bacillus to eliminate false positive culture results. Repeat joint aspiration. And if there is a culture negative prostatic joint infection, please consider the presence of the fastidious pathogen if infection is suspected with a negative culture, anaerobe, mycobacteria, and fungi. Consider tissue diagnosis with history frozen section to confirm diagnosis. There are some reasons for culture negative. Use of antibiotics, samples taken from inappropriate areas and insufficient amount, biofilm formation, and bacteria intracellular localization, low virulence bacteria, short culture period. And the factors that lead to success in the periprostatic joint infection treatment. Period between first operation and emergence of infection. Time period between diagnosis and starting treatment. Microorganism and its virulence. It leads to surgical practice and antibiotics. Deep infection. Patient physiological condition. Fixation type of the prosthesis. Sufficiency of prosthesis fixation. And when we look at the treatment, what is the success rate in 1-stage and 2-stage cases? When we look at the literature, outcome success rate between from 84 to 90% in 2-stage surgeries, and outcome success rate between 80 and 85% in 1-stage surgeries. As you see here, some literature here, and then 1-stage and 2-stage. As you see here, it's more or less the same results. But in the endoclinic, success rate is 85 to 90% in all the periprostatic joint infection cases. Requirements for the 1-stage exchange. First of all, multidisciplinary team, experienced surgical team, anesthesiologist, infection disease specialist, probe identification of the bacteria by joint aspiration, specific and appropriate antibiotics. Advantages of the 1-stage exchange. There is a single operation, morbidity decreases with this method, short length of hospitalization, lower cost, increased patient satisfaction, no delay implantation related difficulties, functional joint is a short span of time. Positive factors that influence the success of the one-stage exchange. There are, as we see here, patients with overall good health conditions, good wound appearance, healthy soft tissue, good bone quality, methicillin sensitive types of staph, streptococcus, microorganisms sensitive to antibiotics, which are added to cement, identifying microorganisms and recognizing sensitive antibiotics. Negative factors. There are some negative factors that influence the success of the one-stage exchange. Polymicrobial infection, presence of systemic or accompanying disease, gram-negative bacteria, methicillin-resistant staph and streptococcus, cement without antibiotics, patient's expectations. And one-stage revision is not enough recently, whereas only one operation done, short time antibiotic using, cost effective. For success, true patients, local and systemic antibiotic using, good, rigorous and multidisciplinary surgery. For the one-stage surgery success, not only implant discharge and tissue cleaning, also radical debridement and high-dose antibiotic using is necessary. More debridement is so important. More debridement is necessary in one-stage surgery than two-stage cases. There are some contraindications for the one-stage exchange. Maracea and gram-negative bacteria, soft tissue cover failure, immunodeficiency, inability to recognize types of preoperative bacteria, failure of one-stage revision more than twice, infection which include neurovascular structures, lack of suitable antibiotics. And when we look at the postoperative period, it's from the endoclinics application, I mean, more than 10 days central IV, 4 to 6 weeks IV antibiotics, and post-op care and rehabilitation, 14 days hospitalization, mobilization with 2 or 3 days, rehabilitation according to the condition of the bone loss and the soft tissue. This is from the endoclinics. And one stage versus two stage exchange, which is successful. In serious literature's reviews, no evidence on the superiority of the 2 or more stage to one stage. There was no significant difference between the 1-2 stage and the reinfection rates. The studies on the fact that 2-stage is the gold standard that have been identified and as expert opinion and evidence level 3 and 4 in the literature. And thank you very much.
Okay,
for your attention.
Thank you, sir, for this great talk. We can ask you some questions, sir. Is there, do you have a special criteria to choose which patient you are going to do one-stage surgery for him and other patient you will do a 2-stage surgery for him? Or you can apply it for all patients you can do first one-stage surgery, or all the patient doing for them 2-stage surgery? Is there a specific criteria if you are going to do always one-stage surgery when you think about 2-stage surgery? Thank you.
Just I would like to say something about that. First of all, we have to know the bacteria which kinds of bacteria we have, the first. And the soft tissue coverage should be good enough, good enough. And the patient stable immune response. If the patient immunodeficiency, please don't do that. And if there is some sinus tract, maybe you can do that. But we have to know, even if there is some sinus tract, what kind of bacteria in the wound. We have to know that. Just I said that if the infection is located on some neurovascular structures, please delay. You have to choose two-stage surgeries. If I say again, very short, we have to know the bacteria. What kind of bacteria? We have to know. This is the first thing. If you don't know, please, two-stage.
Yes, thank you. So a question to Dr. Mahmood. You are usually using mobile spacers for your two-stage surgery. Don't you think that this polyethylene and the femur implant you are going to put may play a role in preventing cure of the joint from the bacteria? Its biofilm can reform again around the polyethylene after doing this in a new spacer. What's your comment about that?
Thank you, Dr. Ahmed, for this question. This is a very important question. It's idea that that's why first slide for me, it's you must expose and you must be clean, if you remember the first slide, because when you are doing the first time to removal the implant, you must clean everything, biofilms, and where there is gutters, anterior, medial, lateral, and the canals and the tibia, to clean your field, surgical field, from the every debridement. This is first. Secondly, for me, when I apply a mobile spacer, actually I am not using the same implant, that sterilization and then to apply it. There is some centers doing that they send the same implant about 60 to 70 minutes re-sterilization, then they coming to do implantation with that implant. For me, no, I am using a virgin and new. That's why it is not thinking about this will be foreign body. And the antibiotic which I am using, I know the germ, and I applied that antibiotic which is sensitive to that germ, so applied it to the tibia and apply it to the femur. So I am engulfing all of, I want to eradicate the infection. But the question is, there is recurrence of the infection? Yes, there is. But it is a limited number, and I have one patient, I did for him 3 spacer because something immune compromised. That's where I did 3 spacer. Then I go to the second stage implantation. The important thing to carry all the procedure that not allowed for the second infection.
Okay, Dr. Ehsan, can we see your case, your solution for your case, please, that you present in the start of the webinar?
Okay. Thank you, Dr. Ahmed. We will proceed with our case. So this is the classification about the infection. Dr. Mahmood and Dr. Belgin talked a lot about it. We think that our case was late chronic infection, which is type 2. So we proceeded with 2-stage revision surgery. All the implant was removed. We take a tissue culture from 4 sides, femur, tibia, 2 from the capsule and the gutter. Good debridement for the soft tissue and the bone done. Mobile spacer all done by bone cement with antibiotic, which was vancomycin. This is the mobile spacer which done for the patient. Tissue culture result was Staphylococcus aureus again, treatment with the proper antibiotic for 6 weeks. Then a new lab test after the treatment was the C-reactive proteins 2, ESR9, white blood cell is 3000. After 3 months, second stage surgery done with CCK prosthesis, and was the final result. We follow up the patient post-op. Patient was free of pain, no knee swelling. Start walking day after the surgery. The range of motion after 5 days from the surgery was 5 to 120 degrees. Thank you very much.
Okay, thank you. So, Dr. Ehsan, a question from the floor. Professor Omar said that he usually re-aspirate the joint before doing the second stage surgery. Did you aspirate your patient? And if yes, what is her parameters before, after the aspiration, before doing the second stage surgery? Thank you.
After the first stage, we follow the patient with the laboratory investigation. If there is no sign of infection of swelling, we don't do aspiration. For this patient, the patient was stable and there is no erythema, no fever, the lab was good, so we didn't do aspiration for her, but we take a culture during the surgery, and the culture come back after the surgery, which was negative. There is no germ.
Okay, thank you very much. A question from the floor to Dr. Omar, Professor Omar, asking if there is any special tricks that you are going to do during doing first one-stage surgery, special tricks regarding eradication of bacteria, washing the joint with special agents, like that. Thank you very much. Would you mind unmute yourself, please? We can't hear you.
Okay, I'm sorry about that. I'm sorry. Yes, it's a very good question. I said that before during this presentation. The important thing is we have to know germ, what kind of germ in the wound. If you want to one stage, it's so important. Soft tissue coverage is so important. The patient conditions is so important. And during the surgeries, the debridement should be more than, really more than the two-stage operations. From the soft tissue, I mean, you have to do very good the debridement about the synovial tissue, first of all. To preserve, during these surgeries, of course, you have to preserve the extensor mechanism and the ligaments. And the important thing is in here, you have to remove some capsular tissues, especially in the posterior part, especially in the, when we look at the posterior femoral condyles, you have to remove, you have to debride all the soft tissue around the posterior part of the femur. It's so important. And if you need, you have, don't hesitate to remove the capsule. Please, it's so important. And after the debridement, I always put the betadine, the full, no any adding the serum physiology, all the pure the betadine with alcohol, 10% alcohol. I have to put at least 30 minutes. Wait. After that, you can change. You can put the component. It's so important. And of course, you have to some aspiration. You have to do aspiration before the surgeries, and you have to know what kind of germ you have.
Okay, thank you, sir. A question to Dr. Mahmood, asking about do you use special agents while you are doing the lavage during the surgery, like iodine, chlorhexidine, alcohol, as Professor Omar using 10%?
One thing, regarding the ICM, this question is also highlighted. Regarding chlorhexidine, they saw that is toxic to the tissue. That's why they apply it to the skin, just to the skin. It's better to apply it to the skin, not to the, in spite there is some percentage, but they saw this because of the toxicity, they be away from it. Betadine, yes, you can apply it with the normal saline. And in revision, at least 10 liter use. In primary, about 4 liter. In revision, about 10 liter use. But the important thing is to clean everything, because there is sometimes risks of seroma. So it's better to clean everything. The important issue in the lavage, when you are using in regarding infection, what Pascal, you know, the lavage has many Pascal pressure, 5, 10, and 20. So it's better to do it slowly, not go to high Pascal more than 20. These tricks you must apply it when you are applying to the lavage.
Regarding the pressure of the lavage, you mean we should use low pressure to spare the bone?
Because from everything slowly, not, because sometimes if you use 20, this means that there is some infection will be distributed in the tissue. So get to 5 or 10, better than 20.
So it is not a part of sparing the bones, about the bacteria.
Yeah.
So Professor Omar, I think Dr. Mahmood answered a question just now and put on chat. The question said that how much the reinfection rate. I think the reinfection rate in his hand about 6%, because 6 or 10% maybe, because he has only 3. He mentioned that he revised in the last year. So how much the reinfection rate after 1-stage surgery or 2-stage surgery that you do in your practice, not in literature?
Yes, just I would like to say one thing I would like to add before the question. You have to put the sensitive antibiotics in the. You have to add the antibiotic in the cement for fixation. Okay, and that's another tricks. It should be, and in our clinic. When I use the 1-stage, its reinfection rate is more or less 7%. It's not to reach the 10%. But when you want to use 1-stage exchange procedure, you have to choose the very good patients. The choosing of the patient is so important. I said before, it's so important.
Yes, that's our first question to you. So, Dr. Mahmood, I think most of the attendees are Iraqis and asking about something related to their practice. what is the most common type of organism that you have been collected from your infected knees?
Staph aureus is the most common
In Iraq.
germ. Yes, Staph aureus, sometimes Staph epidermis, but keep in mind some of the cases I saw it is E. coli.
E. coli.
Yes, E. coli, which is that's why I have this recurrent revision. They are the E. coli, but most of
I
them
think
Staph aureus.
I was a fellow with you when we collect the E. coli.
Yes, and we have one fungi, you know, that cases,
Yeah.
and you know, always I'm saying is prevention is better to treat this disaster complication.
Okay, Dr. Omar, Dr. Mahmood, using the prosthesis, a new prosthesis with polyethylene, and using it as a mobile spacer, which one is better? This type of mobile spacer, or using a cemented modulated? You do it during surgery, or there is a module already, and you can make a cemented mobile spacer. Which one you prefer and why?
I use the fix polyethylene to get a stable joint.
Stable joint in order not to lose the
Yes, especially in the primary cases and revision cases. Okay.
Why you use the fixed spacer? Do you think?
No. Just. I'm sorry about that. I confused the. I answered this question about the polyethylene.
Yeah.
Okay. I don't use the mobile polyethylene, but when you look at the spacer, I always do the handmade and the mobile spacer. I always use that.
Why do you think a polyethylene?
Because as you know, spacer gave us the space during the surgeries, and we have to need the more range of motion after the surgeries. Yeah. If we use the fixed spacer, the surgeries will be difficult.
Yes, but
exposure. Exposure.
Exposure, yes, but I think when you use a mobile spacer for 3 or 4 months and the patient will start to walk on that mobile spacer, I think you are going to jeopardize the posterior condyle.
Yes, of course. Yes, of course.
So
but
that doesn't a big deal for you.
Yes, okay, but how can I prevent this? There are some holes, intramedullary canal. Yeah. You have to use as a fix to fix it the spacer. I mean the cement. You can put some cement with spacer as a block to the hole, and then after that it's fixed. There is no problem after that. Okay.
Okay, thank you. So, Dr. Mahmood, do you think one of the attendee asking about your case you have been presented already, that the infection with malunited fracture. He's asking, do you pay any attention for the mechanical access of that knee after doing your revision surgery? And if you do, if you have an X-ray to show him, please, or not?
I think the X-ray, I saw it to you, but the important, I think the kind of war about the extra-articular deformity. I think is talking about that extra-articular deformity. You know, extra-articular deformity If it is 20 and less, it's nothing to worry about it. And secondly, the
in valgus or varus or what?
extraarticular deformity, yes, maybe in valgus or in varus, sometime in posterior alignment. But if it is less than 20, it is no problem, extraarticular deformity. And exactly in this case, also when we did, actually it is less than 20 because it is, yes, malunited. But fortunately, the stem about 10, 100 is reached just to the site of the deformity. So I doesn't need for corrective osteotomy. But sometimes, if there is extra-articular deformity that not be corrected intra-articularly, so I must get corrective osteotomy. Then I apply my joint, maybe long stem, or sometime for the plating. But for this, it is alignment. I showed the last picture, alignment is straight, but the patient actually has also foot drop, severe sciatic nerve injury.
Yeah.
That's why he's walking by shuffling. I did it before 1 month. Arthrodesis, that to keep straight, aligned limb and stable. So more than 20% extra-articular deformity that not correct intra-articularly, you must go to a corrective osteotomy of the bone before the applying long stem to pass the site of the correct osteotomy.
Okay, thank you. Dr. Omar, is there any principle to fix a tubercle osteotomy after doing that for your knees? You fix it with the plating, or is it enough to use the K-wires and screws for the tubercle osteotomy? How long, what is the post-operative care for this patient with tubercle osteotomy? Will you prevent flexion of the knee, put it straight, or what?
Yes, first of all, the important question. In some cases, if the bone quality is very well, you can use at least 3 screws. If there's some problem of quality of bone, please, you have to use K-wire. I mean the circulage, okay? With circulage. And it should be three circulage. And you have to put the circulage obliquely from the distally to the up. It's very helpful to fix the tuberosity on the host bone, I mean the tibia.
Yes.
It's so important. And at least 3 screws and 3 circulage. And the length of the osteotomy site, at least 7 centimeters,
Okay.
at least. Okay? And the post-operative rehabilitation it's the same. You have to allow the patient full weight bearing and flexion. There is no problem.
No difference.
If the fixation is well done.
So, Dr. Mahmoud, have you been facing an infected joint with severely infected patella? Have you removed a patella because of infection? And is it spared from the infection? Usually, we are not talking about the patella and what shall we do for the patella. Is there any role of debridement, removal of part of the patella, doing something, or what?
Actually, patella is part of the knee joint. Always, also, it will be infected. The biofilms, especially if it is like a poly, it's the biofilms, you know, is collecting this in poly more than the implant. So patella is part of the story. Whenever you're doing removal of implant, I face the infection in the patella. That's why I am cutting the patella and keeping the 2-stage. I cut it because difficult to extract it. from the pecs. Then I remove the pecs and clean. It needs very aggressive cleaning regarding the patella, and try to remove one layer from the what's remnant there, and keep it even if it is thin. I keep it because patella knee with thin patella is better than without patella. Patellectomy is disasters regarding the extensor mechanism. Extensor mechanism is the most disaster in the knee. So always I try to clean it, but keep the patella even it is thin. Later on I can do what is type of the thickness of the patella. But keep in mind, patelloctomy is a disaster, and it's part of the story, part of the infection.
Yes, I think this question came before, when we took a specimen for sending 4 or 5 samples from the joint, sending for the lab. Nobody take care of the patella. We are usually taking a sample from the femur, tibia, posterior capsule, lateral gutter, medial gutter, but nobody say, please take a part of the patella and send it to the lab. So
Yes, yes, yes. But
I
Ahmed,
think
if
we
there
have
is
to pay some attention to this great and very
uh,
important part of the extensor mechanism. Okay, I think I finished all the questions that have been asked from the audiences. I want to thank the faculty, Professor Omar, Dr. Mahmood, the consultant of knee surgery in Iraq, and Dr. Ehsan. Thank you very much. Thank you for all the attendee, and we hope to see you in our next webinar for the Iraq Recon, not AO. Thank you very much. Thank you, Dr. Omar. Thank you, sir. Thank you.
thank you very much. Bye-bye.